Last but not least, we have Rebecca Hughes from the Golden Jubilee National Hospital in Glasgow to tell us about assessing coronary artery calcification to predict cardiovascular complications in colorectal cancer patients.
Hi, I'm Rebecca Hughes. I'm a clinical fellow in general surgery in the Golden Jubilee Hospital, and I'm going to talk to you today about assessing coronary artery calcification to predict cardiovascular complications in colorectal cancer patients. So most people in the room will probably know that the Golden Jubilee Hospital is well known for its cardiology, for its cardiothoracic surgery, but in the last few years they've developed a colorectal elective service as well, which is sort of how this has all come together. So this has been done with Professor Susan Moog, who's a colorectal surgeon, Dr. Richard Good, who's a cardiologist, and Professor Ben Shelley, who's an intensivist and anaesthetist. So I'll give you a bit of background of how we've come up with this idea. So all patients who go through the colorectal cancer MDT have imaging of their chest, abdomen and pelvis. This is primarily to look for any metastatic spread of their colorectal cancer. But obviously when they've got their chest scanned as well, coronary artery calcification is rarely reported on these scans, despite a recent consensus statement in 2020 by the British Society of Cardiovascular Imaging said that all incidental coronary artery calcification should not only be commented on, but should be ordinal scored. So we undertook a snapshot audit to assess how often it actually is reported in general surgery patients. So to decide what cohort of patients to look at, we had a look at 18 elective colorectal resection patients and 21 emergency laparotomy patients, and found that actually less than 15% of emergency laparotomy patients have imaging of their chest preoperatively, so immediately excluded this group. And when we looked at that, of those 21, none of them had a comment on coronary artery calcification, just for interest. So in the elective colorectal surgery group, all of them had imaging of their chest, but only 28% had a comment on their coronary arteries. So the incidence of coronary artery or of cardiac complications in non-cardiac surgery is described up to 18%. So it's a significant burden on these patients. And there are a few methods that can help predict cardiac risk preoperatively, but none of these include radiological evidence or looking at the imaging to see if there's any coronary artery calcification. The two most commonly used, although I would say none are commonly used, are the Revised Cardiac Risk Index, which is a Lee score, and the National Surgical Quality Improvement Programme, NSQIP, and they look at a variety of modifiable and non-modifiable risk factors to try and predict perioperative cardiac risk. So from that, the aim of this study was to determine if there's a link between the burden of coronary artery calcification and the likelihood of a postoperative cardiovascular complication in colorectal cancer patients, but also to determine what the incidence of coronary artery calcification is in these patients, and if there's a link between pre-existing calcification and any complication, but also to consolidate the existing risk scoring systems with radiological evidence of coronary artery calcification. So to be included in this study, you had to have a confirmed or suspected colorectal cancer with an MDT decision that you were to have surgery with curative intent. The procedure had to be intra-abdominal, so it could be lap, it could be open, it could be robotic. You had to have a CT chest preoperatively, and you had to be over 18. And exclusion criteria, so if someone was having a planned palliative resection, so defunctioning stoma for an obstructing cancer, they were excluded. Or if a patient had an unplanned admission to hospital and ended up having their operation during that time, or if they had an endoscopic or transanal excision of their colorectal cancer, they were also excluded. So this was a retrospective review of a prospectively maintained ERAS database. That's the Enhanced Recovery After Surgery database, which is national. It was from a single centre, and it was from February 19 to January 2020. Now, this timeframe was chosen specifically to exclude the COVID disruption to service. Surgical services changed quite a lot during COVID. There was a lot more open surgery for a while, and a lot of surgical services moved to private hospitals, so there was less availability to look at their post-operative complications to get accurate data for these patients. Collected demographics on age, gender, BMI, things like that, and then also calculated a NSQIP and a Lees score based on their preoperative information. So went on to collect their cardiac and non-cardiac complications up to 30 days and the endpoints that I used. So for the cardiac endpoints, it was the standardized endpoints in perioperative medicine. This was a consensus statement following a systematic review of perioperative cardiac complications in non-cardiac surgery patients. And for the non-cardiac complications, we used the post-operative morbidity scoring, which had 9 categories, one of which was cardiac, which removed, so which left with pulmonary, infective, renal, gastrointestinal, neurological, hematological, wound problems, and pain. So how did we assess the CT scans? So we underwent training under the supervision of an interventional cardiologist who regularly calcium scores dedicated ECG-gated CT scans in a cardiac hospital. We ordinal scored, which was done by assessing each of the 4 main coronary arteries in turn: the left main stem, the left anterior descending, right coronary and circumflex artery. Each vessel was divided into thirds and allocated a score of 0 to 3 based on whether there was calcium seen in each third of the vessel. And the sum of each vessel was then calculated to give a score out of 12. And this is a previously described way to ordinal score in the literature. So if there was no calcium seen, they have no coronary artery calcification. If their score was 1 to 3, it was mild, 4 to 6, it's moderate, and 7 to 12 was severe coronary artery calcification. Then to validate these scores, because they were done by surgical trainees, a proportion were reassessed by an interventional cardiologist, and inter and intra-class correlation coefficients were applied to assess for discrepancies. So the results, so of the 100 patients that we looked at, there was 57 men, 43 female. The average age was 68 years, and this ranged from 37 to 90 years old at the time of surgery. There was 1 mortality within 30 days of surgery, and that was owing to stroke and hospital-acquired pneumonia. Of these 100, only 9% of patients had a comment on their coronary arteries by the radiologist at the time of CT, despite the consensus that I've spoken about already. And when these scans were reviewed by us, 79% of patients had evidence of some coronary artery calcification. 7 of these 79 patients had a cardiac complication within 30 days, and all of those had some evidence of coronary artery calcification on their CT. There's a significant difference in the complication rate, both cardiac and non-cardiac, between the group that had any identifiable coronary artery calcification and those without any. But there doesn't seem really to be a link if there was mild, moderate, or extensive calcification and the amount of the complications. It seems to just be either none or any. So as I said, that we calculated a Lees score and a NSQIP score for each of the patient based on their preoperative information, and the graphs here show that calculated score compared with the ordinal score that we had allocated to each CT scan. And it shows that as the severity of calcification increases, the Lees score and the NSQIP score also increase. Note that the Lees score is out of 6, and all of these patients score at least 1 because they've had what the Lees score deems as high-risk surgery as an intraperitoneal procedure. So for the validation, 30% of the scans were reassessed by an interventional cardiologist at random, and that's someone who regularly calcium scores CT scans. The inter and intra-class correlation shows good level of consistency and conformity between assessors. So in conclusion, coronary artery calcification is significantly underreported on CT. Non-dedicated CT is reliable and reproducible method of assessing coronary artery calcification. Post-operative cardiac complications are common and associated with morbidity and mortality. An identification of coronary artery calcification preoperatively can ensure time for risk modification, targeted use of further investigation, and as well as guiding the anaesthetist for perioperative monitoring.
Did you happen to look at high-sensitivity speech recordings in these patients as well?
No, so we've talked about doing this then as a prospective study, and that's what we aim to do with that, to try and involve some biomarkers.
I'm wondering about your intervention. So what I'm interested in is what you can change. So what can you change?
So I think the first thing to say that this was completely to do with risk, and there wasn't any intervention planned for this group. It was a retrospective study just to sort of identify how common it is and what the problem is. I think we'd need to take advice on what would be possible and who then, you know, helps with this intervention. There's things like CPET testing that is used but is a limited resource, and it could sort of just, you know, decide who's a little bit more high risk, who needs this intervention. Or so these are, yeah, for operative ones, but you can do things like if you could start a statin if they're not already on one, if you could get them, even if this patient's in their 40s, and say, you know, you've got evidence of coronary artery calcification, if you stop smoking, lose some weight, and, you know, stop drinking, that's great. And it might just be that sort of wake up call that, yes, you've got bowel cancer, but also you've got other things going on. Yeah. It wouldn't be something that would stop the surgeons operating if the patient was on aspirin. I would have to take advice from cardiology on that.
Michelle.
Oh, is that working? Great. Hi, lovely talk, thank you. This might be a bit of a daft question, so apologies if that's the case. I'm just wondering, why did you exclude patients that could have an endoscopic approach or transanal approach? Just given...
Yeah, so the patients who have had endoscopic or transanal, well, more endoscopic approaches would be people who have polyp cancers. So they've had their index colonoscopy. They've had a polyp removed. When it goes to the lab, it shows that there's cancer in the specimen. And if that's been completely excised, then they don't go on to have another operation.
Thank you, that's great.
Rebecca, what proportion of patients had pre-existing coronary artery disease? Did you look?
So in Scottish studies that have been in general, patients
in your cohort, did you? Any of them have pre-existing diagnosis of coronary artery disease?
It varied a bit, and it was a variation because a lot of this came from their preoperative assessment. There would be, you know, you could see that some of them are on statins, but they didn't have any sort of comment ever that they've had coronary artery disease or ischemic heart disease, but you could see maybe hints that someone has started something. There were obviously ones that had AF preoperatively, were anticoagulated, had MIs in the past, and I have got a note of them, whereas these were looking for new complaints.